Hi, my name is Arun Natchiappan. This is an introductory lecture on CT Pulmonary Embolism interpretation. At the end of this session, you should be able to assess quality and identify limitations, distinguish PE from artifact, compare and contrast acute and chronic PE, evaluate for right ventricular strain, and discuss optimization techniques. Here is a set of questions to ask yourself while interpreting CT pulmonary angiograms. We will go through each of these questions. The first question to ask and answer is, what is the exam quality? Quality assessment is based on which level of pulmonary arteries we can clearly see to. The contrast opacification of any vessel needs to be greater than 100 Helmholtz units in order to evaluate it. We have high, moderate, low, and non-diagnostic quality categories. High and moderate qualities are fine. On a low quality exam, we see only the central PAs to the lobar level, but not the segmental or the subsegmental levels. If the provider has low suspicion, this often suffices. But if high suspicion, the provider may request a repeat CTPA or a lower extremity venous ultrasound. On a non-diagnostic exam, we cannot see the central PAs to the lobar level. Also, if the main PA is less than 100 Helmholtz units, it is non-diagnostic. Ideally, we would rescan the patient with optimized technique. The next question to answer, any limitation that significantly limits evaluation? Let's identify these limitations and artifacts first. Suboptimal contrast opacification, transient interruption of contrast, pulmonary motion artifact, streak artifact, and image noise. To problem solve for these, use an optimization technique checklist that we will discuss later. Suboptimal contrast opacification is when the ROI on the main PA is less than 250 Helmholtz units. This is different from an optimal example shown on the right. Think of transient interruption of contrast when the main pulmonary artery has suboptimal contrast, but you see a bright SVC and bright aorta. This is because of an influx of unopacified blood from the IVC, which can happen when a patient takes a deep breath immediately before the scan. In this example, an apparent filling defect turns out to be pulmonary motion artifact when you look at the lung windows and see blurry vessels. Several filling defects radiating from the SVC indicate streak artifact from dense contrast. If the arm is down, streak artifact from the arm can cut across a vessel. Image noise appears grainy in a patient with large body habitus. Next, let's identify these limitations and artifacts: flow-related artifact, low cardiac output, parenchymal disease, and bronchial artery inflow artifact. To problem solve for these, you can use a delayed PE technique that will be discussed. A flow-related artifact is wispy with ill-defined margins. If you zoom into the filling defect and place an ROI well within it, the density will be high, which is typical of artifact, not acute PE. With low cardiac output, global slow blood flow results in little or no contrast in the peripheral pulmonary arteries and veins. A clue is when the left atrium is not well opacified. Parenchymal disease results in focal slow blood flow. Here there is non-opacification of pulmonary arteries in the involved region. Think of bronchial artery inflow artifact if you see a convex lunar shape in non-dependent lower lobe pulmonary arteries, or a jet-like filling defect and non-opacification that extends to distal branches. This is due to bronchial artery anastomosis with the PA branch seen when the aorta is not well opacified, but which resolves on delayed aortic phase as shown here. Think of this when there is bronchial artery hypertrophy, severe bronchiectasis, or fibrosis. The next question to answer is, what is the best conclusion regarding presence or absence of PE? Let's distinguish between acute PE and artifact so we can avoid false positives. This saddle PE has a well-defined margin. This flow-related artifact has an ill-defined margin. This acute PE is longitudinally oriented to the vessel. This streak artifact is perpendicularly or obliquely oriented to the long axis of the vessel. Moreover, the ROI shows a high density, which is again typical for artifact, not acute PE. This apparent filling defect is a mimic of a PE. The vessel can be followed to the left atrium, and so it's a pulmonary vein, not a pulmonary artery. This apparent filling defect is a mimic of a PE. It is a mucoid-impacted bronchus seen on lung windows, not a pulmonary artery. This chronic PE is eccentric and appears inside the vessel. This hilar lymph node is outside the pulmonary artery and is a mimic of chronic PE. This web-like filling defect within a vessel lumen is a chronic PE. This is a mimic of a chronic PE representing a vascular branch point, evident while scrolling and on coronal or sagittal. We can use these tools to distinguish between PE and artifact. Is it a pulmonary artery? Can this level be evaluated? Can it be explained by an artifact? Look at the lung window. Is it oblique or ill-defined? Use ROI as an adjunct tool. Look at the coronal. Let's use these tools on a case. Here there are two filling defects. The medial one can be traced to the left atrium and is a pulmonary vein. The lateral one is a pulmonary artery. But if we switch to lung windows, there is pulmonary motion artifact on the lateral vessel. Also, if oblique to the long axis of the vessel, it is artifact. On this new case, there are two filling defects. One is shown on this slice. This is a moderate quality exam where we can only evaluate to the segmental level, but this is a proximal subsegmental level, so we will not evaluate or comment on it. The other apparent filling defect is more proximal and is co-localized on the coronal, where we can see the stair-step artifact, indicating that it is pulmonary motion artifact. We can use the following tools to identify subtle PE and thereby avoid false negative. Use a careful search, look for an abrupt change in density of the vessel. If there's a subtle finding on axial soft tissue kernel, it can be confirmed on lung kernel, inverted soft tissue window, and by co-localizing to coronal or sagittal plane. If there's an isolated subsegmental PE, it may not need to be treated depending on the clinical scenario. You can ask the provider to consider a lower extremity venous ultrasound to assess for DVT if the decision for anticoagulation is uncertain. If a filling defect is more likely artifact than SSPE, don't call it. If equivocal, you can state possible isolated SSPE with low confidence versus artifact. Now let's compare acute and chronic PE features. We can start when it's partially occlusive. This acute PE is in the center of the vessel, whereas this chronic PE is eccentric. It is useful to look at the prior exam to see if the filling defect is new. This acute PE is eccentric and makes an acute angle with the vessel wall, whereas this chronic PE makes an obtuse angle with the vessel wall. Chronic PE can appear as a thin web or show recanalization of a clot with contrast channels. Let's move on to when it's completely occlusive. This acute PE expands the artery compared to similar vessels, while this chronic PE contracts the artery compared to similar vessels. Here are some tools to differentiate acute and chronic PE. Is there a prior exam? Is the PE in the center of a vessel? Is there a change in vessel size at the PE? Let's use these tools in a case. Here's the filling defect. Is the PE in the center of the vessel? Yes, it is. So this is acute. How about this one? It's eccentric, so it's chronic. For this filling defect, is there a change in vessel size? Yes, it's contracted, so this is chronic. For acute PE, you can estimate the obstruction of overall PA circulation. It's small if less than 20%, moderate if 20 to 40%, and large if greater than 40%. These are the next questions to answer. In what location is there a PE? What's the most proximal level with the PE? Let's start with the central levels. The main PA gives rise to the right and left PA. Each side gives rise to an upper lobar level and an interlobar PA, which is in orange. The interlobar PAs give rise to either a right middle lobe or lingular lobar level, along with the lower lobar levels. All the lobar levels are in yellow. Next, let's look at the peripheral levels. The segmental levels are in blue, starting with the upper lobe segmental levels, then the right middle lobe and lingular segmental levels, next the superior segmental PAs, then the 4 basal segmental PAs on each side, which are important to look at while assessing quality of the exam. Subsegmental level is not shown, but is beyond the branch point of a segmental level. The last question to answer is, are there any ancillary findings of PE? Ancillary findings include sign of right ventricular strain, dilated main PA, right heart clot, and pulmonary infarct. Evaluate for sign of RV strain only for positive PE. RV strain can affect the risk category of PE. For the RV-LV ratio, measure the RV and LV diameter. At the level of the valve plane, choose the widest axial slice for each, avoid the membranous septum, measure from free wall of endocardium, inner wall to inner wall, staying perpendicular to the septum. Over here, there is right ventricular strain. RV-LV ratio is greater than or equal to 1, and there is interventricular septal flattening. Meanwhile, over here, there is no right ventricular strain. The RV-LV ratio is normal, and there is no septal flattening. The main pulmonary artery is dilated if greater than 3.1 centimeter in diameter, which may reflect elevated pulmonary arterial pressure, such as in CTEPH. It's only rarely due to obstructive acute PE. Right heart clot is rare. It has well-defined margins. This is different from more frequent mixing artifact, which has ill-defined margins. Look for pulmonary infarct on any CT, with or without contrast. It is wedge-shaped peripheral opacity which may have mixed attenuation. Now that we've answered all of our questions, we can put them in the report. This is a structured report with pick list choices for quality, limitations, findings, and impression. If non-diagnostic is selected in the impression, a rescan can be performed. For most rescans, we can use this optimized technique checklist. The following first address suboptimal contrast opacification. Look at the monitoring phase, make sure the ROI was placed correctly, get better IV access, increase the contrast rate, and decrease the KVP. Consider dual energy technique if available. For transient interruption of contrast or pulmonary motion, do breath hold coaching. Consider expiration phase for transient interruption of contrast. For image noise, you can do a large PE protocol if large body habitus. If streak artifact from SVC is the main limitation, you can decrease the contrast rate and volume at lower KVP settings. Consider dual energy when there is suboptimal contrast opacification, particularly when 1 to 2 additional problems. But a contraindication is severe pulmonary motion artifact. Here, contrast opacification was improved upon rescan with this technique. On the other hand, you can use a delayed technique for these limitations: flow-related artifact, low cardiac output, parenchymal disease, and bronchial artery inflow artifact. Delayed phase acquisition can capture slow PA flow and systemic arterial inflow into the PAs. In conclusion, we did the following: asked and answered questions to interpret CTPA, assessed quality of exam and identified limitations, distinguished PE from artifact, differentiated features of acute and chronic PE, evaluated for RV strain, and discussed optimization techniques for problematic CTPA. Thank you for your attention. I hope you found this lecture helpful.